I like my ghetto hoodies.
Hi everyone, how's it going? We'll just give people a few minutes to come in before we start.
Hey everyone.
Hi everyone, how's it going? Hi Dr. Shelby there. We're just waiting, giving people like maybe another 2 minutes to come in and we can start if that's cool with everyone.
Yeah, that sounds great. Okay, whenever you all want to get started. Do you mind if I just say a couple words before
Yeah, of
you
course.
set up? Okay, so I just want to let everyone know, I know we have some new faculty here. So our fellows do a QI project every year, and they work as a team, everything from start to finish that they'll tell you about. And I just want to say I'm so proud of them. They've worked really, really hard on this project and excited to hear their presentation. So turn it over to all of you.
All right, guys, thanks for joining us. So just want to introduce everyone before we get started. We have T. I don't know if you can see us. We have Yama, Laurel, Isaac, Misha, my name's Omar, and then our team leader, Peruz, who is at the VA.
Yes, zone office.
Yeah,
Hi,
he's
how are
in
you
the office. All right, so. Ready. So our quality improvement project was on a pediatric O2 titration studies. So
We have no disclosures and first person, BT.
So, obviously this quality control project, we want to pick something that can have profound effect that affects multiple domains in healthcare. And to really, examine the effectiveness of this program, we need to make sure that, it should certainly maximize the safety in which, all steps are taken to protect the patient from harm. as well as preventing medical mistake and injuries. We want to make sure that there's effectiveness in which the service achieves its intended purpose. And we want to make sure that it's safe and is provided to the desired benefits of the patients. We want to make sure that it's patient-centered to where we do like take into the patient perspective when it comes to our solution. We want to make sure that it's being delivered at a timely manner in order to achieve the best possible care. And certainly we want to make sure that there is efficiency in how our hospital system utilize the resources to get the desired output. And certainly whatever solution we provide should have equal equities among all the patients, to where everyone would receive the same treatment. And so how do we actually, measure how well the patient will receive this solution? There's certainly five social determinants of health, including education, access and quality, healthcare access and quality, neighborhood and built environment, social and community context, as well as economic stability. And they all seem to affect a patient's health status, as well as their life expectancy, their mortality, their morbidity, and the healthcare expenditure, as well as potentially increase their functional recovery. And in this context, we're mainly focused on the healthcare system, or how, what are some of the things that we can do to better, maximize and improve these quality metrics. Certainly, there are other aspects as well that we try to take into account. For example, such as the social economic aspect, to ensure that there is no waste in terms of medical bills, as well as the effectiveness of it. And then, so how do we actually tackle this? And it's a very interesting proposition. And I think we turn to the template that the majority of institutions use in the past in order to figure out the problem and also to get into an optimized solution. And it's called the A3 problem solving template.
Yeah, so I wanted to kind of give a brief history of what the A3 problem solving template is. So everyone's familiar with Toyota, the car company, right? It's a Japanese industrial company. And in the mid 1970s, there was a big problem with the leadership skills of the managers. So they had this quality control program in place called the TQC, which stood for Total Quality Control. But the director manager of Toyota at that time, Masao Nemoto, his picture's up here, he saw that the management capabilities, especially among the administrative and non-productive divisions, were declining. So he created this program in 1978 called the Kanran Norioku program. And the goal of this program was to develop the capabilities among mid-level managers across Toyota. So the A3 became a central tool in the ConPro initiative. Why is it called A3? It's based off of the paper they used. It was like a 11 by 17 inch sheet of paper that contained all the things that we're gonna see soon. As the program progressed, it kind of became clear that the A3 was not just a reporting tool, but it was actually a framework for managing, thinking, and communicating amongst all different divisions of the company. The presentations used in the A3 were central. So managers would present their problems and improvement efforts twice a year. The presentations were then followed by Q&A sessions where senior officers would focus on understanding the root causes of the issues rather than attributing blame. And that became very important. It also fostered a culture where admitting mistakes wasn't a bad thing anymore, and learning from them was seen actually as a virtue. Nemoto and other senior leaders then praised the managers openly who reported these problems and mistakes in their A3 reports. They saw this as proactive leadership and honesty, and they encouraged this type of behavior. The focus on developing subordinates and mentoring others also became a core value by using the A3. And it became kind of embedded into the Toyota's broader leadership culture. It's part of Toyota's it's essentially part of Toyota's identity and management culture nowadays. And it's a symbol of Toyota's commitment to continuous improvement and clear communication. It's also used in other different industries now. All sorts of different companies are starting to use this sort of this central tool. So how will the A3 kind of help our project? I just wanted to just like look at the kind of this slide here. So just kind of going back on what what Nemoto was envisioning. So like top management, the middle management and operational staff. He thought it was the top management's like responsibility to come up with future standards or devise current standards and innovate. Middle management had to kind of continuously work to improve those standards. And then the operational staff, their responsibility was kind of to follow and maintain the standards. And that's how he believed that, you know, we could just keep being innovative, but also making sure that there's no gaps in the system. And then if we could go to the next slide, please. Yeah, so this is the 11 by 17 inch sheet of paper that was used with the problem presentation, the direct causes, the root causes, the action plan. And I'll kind of go into this on the next slide. Could we go to the next slide? Okay, cool. Yeah, so how will the A3 kind of tool help us in our project? So we believe it will encourage us to gain clarity and concise thinking. As the format has limited space, as you saw in the previous slide, it kind of forced our group to focus on what truly was important. Also, by using the A3, we hope to develop the essential skills like problem identification, root cause analysis, clear communication, while prioritizing relevant information as well. So it's kind of combining problem solving with continuous learning and improvement, also promoting a culture of clear communication and trying to, you know, not put blame on certain parties. So the key steps of the A3 problem solving includes defining the problem. So that's the background, the context. So clearly articulating what the issue is using data and objective facts. Then we want to kind of break down the problem, the current condition, right? What is the root cause? And there are methods like using the 5 whys or the fishbone diagram to kind of go into this in detail as well. And then kind of setting goals, right? What do we want to achieve by solving this problem? And then also analyzing the situation by gathering data to understand the current state and where the gaps are and why the problem is still persisting, developing countermeasures, design solutions to address the root causes, and then implementing these solutions, right? The implementation plan to put the countermeasures into action. Then there's the follow-up period and the conclusion where we monitor the results and ensure the solutions are effective over time. So throughout this presentation, we're going to kind of go through all of these steps. And I believe the next section is going to be the process itself. I think Dr. Jalal is presenting that.
Hey there, everybody. So,
problem selecting, sorry.
Any solutions, one of the most important things we have to come across is actually selecting the problem. And then, so you have to ask yourself, how do you select a problem? Because we have a bunch of them, so we need to hone in and consider certain things in order to select any specific problem that we have. So there's kind of like 2 domains that we always have to like keep in mind. One is what type of problem you're trying to actually consider, right? And within that domain, we have to like talk about the size and the complexity of the problem, because within that, then you can talk about what exactly is directly in the team's control. And that way, once you hone more of that around, then you can actually put more energy that exists around the specific problem that you can address, rather than, you know, trying to figure out something that's more of an add-on, like something that's more just a side problem rather than the actual main problem that can affect everything else. There are a few things to just avoid generally as what we like to call pitfalls, and normally it's that you don't want any like clear repeatable process, so if you have a mistake that happens over and over again, you don't want that. You don't want to have a problem that doesn't actually have a quantifiable metric, because in future reference, like even if it's in research, you have to be able to like measure something. And so it needs to be quantified in order for see if it's actually addressed or not, how well it's addressed. The last part is that you always want to be within the alignments of the organization, like priorities, because you don't want to misuse the organization's resources, right? This problem should address something that is a problem for the entire organization, not just for yourself. And we can go on to the next slide. So then the question is, how do we, and so then we go on further, how do we actually select the problem? So let's go back really quick. I think it's important to actually understand what a quality improvement project really is. It's just essentially an enhancement of any like quality of a service or product that through analyzation and implementing changes will improve that said quality, right? So you go back, you look at what's wrong, and then you want to like direct exactly how you want to improve something. One big like part of a quality improvement project is, like I said, trying to figure out what exactly the problem is, because you can offer solutions, but if you offer a solution and you're not knowing what the problem is, there's no saying that that said solution will actually figure out what your actual problem is. So it's always important to go back to step one to figure out what the problem is before offering a solution. All right, so our problem specifically. So the way we kind of like went about doing this is that we brainstormed about what is the question we most get called for, whether it's pages, calls, questions from protocol. Generally, this is what we like revolve most of our energy around, because this seems to be a very common problem for everyone. Again, going back to the organizational priorities, right? It seems to be a priority amongst everyone. So amongst like all three of those, how we gathered and brainstormed around, it seems like the most common question revolved around supplemental oxygen titration. And specifically, those questions included like starting with or without oxygen, at what rate the oxygen is titrated, and what the maximum oxygen setting should be. And as you can see, having all these questions, we'd have to go back to the ordering position and we'd have to weigh. And so as you can tell, like having a lot of these questions can take some bit of time, and it could delay management and treatment for a patient's symptoms or a patient's sleep issue. All right. So one way to actually select the problem and overall look at it to, further define a solution, you have to scope the process. And so there are two big steps on scoping this entire process for problem solution. One is to define where the process begins and where it actually ends. So you want to measure specifically what problem you do have and at what point you want to fix it at. And then you have to clarify what's actually within the scope or out of the scope of the process, because again, you don't want to waste organizational resources or your own time specifically trying to fix something that is actually not going to benefit you at the end or not clearly addressing the problem. And so one important part is you always have to understand the complexity and the quantity of information needed, because you need to do all this within a reasonable timeline, right? And one method of scoping out an entire process is something through called the Gemba walk. My colleague Omar is going to talk about that in a few slides. Yeah. And so one, I guess like an organizational way to how we scope out the process is that there's this, it's SIPOC is what I like to call it, but basically it's essentially an idea of suppliers, inputs, process, outputs, and customers. So if I were to give you an example of how this can work, is that if someone, if like a restaurant makes cheeseburgers and the cheese gets bad, or the customer complains that the cheese tastes sour, you kind of go back in time and try to figure out where exactly in time did that cheese get bad? Is it the supplier? Did, the cooks accidentally, do something to the actual cheese? Is it handling the actual food itself? And as you can tell, this process can be used for essentially almost any problem that you're trying to go step by step to figure out a solution for. So if you go to the next, when we are on this slide specifically, we can actually put people that we are constantly in communication with and working with, and we can fit them into these categories. So for example, our suppliers are often the patients and on-call physicians. And to give you an example, the reason they are the suppliers is because they come to us with a specific problem or order, right? And so they are the supplier of what we need to address. And then the input is specifically what goes into like the sleep study, what protocols are there and whatnot. And then the actual process itself is us going through the protocol, us figuring or doing the actual sleep study specifically. And then when the protocol is finalized, the customer itself, which is person who ordered it or the technologist who was actually reading the study preliminary or the patient themselves. And so now I'll move on to the Gemba walk on how we did this.
All right, so the Gemba walk, this was a pretty integral part of, I think, our whole quality improvement project. And so what a Gemba walk is, it's actually a term in Japanese that relates, that means the actual place. The purpose of a Gemba walk is to observe the work process, identify inefficiencies, and gain feedback from employees at all levels of at the work site. And it really allows us to get an unbiased understanding of what actually occurs in a process or in a workflow. And what it's specifically is not, it's not the time to find out who or what is the root cause of the problem or even how to fix it. It's more of an opportunity for us to learn more about how the process is conducted and who all is involved. So there's 3 P's of the Gemba walk is purpose, process, and people. So purpose, you want to understand why you're doing it and why it matters. And specifically, you want to know if the people who are doing the actual work, do they understand why they're doing it and for what purpose? And the process, you want to analyze the process so that you can identify areas of improvement in the workflow itself. And then the people, you want to interact with people at all levels of the workforce in order to understand what their process looks like specifically and how it fits into the overall structure and work model of the workplace. So these are the key elements of with Gemba walk. You have your observation, engagement, questioning, documentation, and action. So observation, you want to take a step back and see how everything is how the workflow actually is. Engagement, you want to involve everyone in, especially in healthcare, and specifically related to our field. We have a lot of people from all different types of backgrounds that are helping to take care of patients and to make sure that everything runs smoothly. So we want to get everyone's perspective and see if there's any issues at each and every level. And then you want to ask employees about their tasks and workflow, and you want to make sure you record your observations and have discussions about it. And then finally, you want to take action based on your unbiased observations and also discussions. And then our Gemba walk specifically, so what we did was we spoke to several different people at different levels of the process. So we talked to the ordering clinicians. This included adult and pediatrics from different specialties as well. So not just sleep, it was also cardiology, pulmonology, ENT as well, internal medicine, family medicine providers who were ordering sleep studies. On the process of how they order sleep studies, if there's any ambiguity in the order itself, and to determine how they initially decided to either start a study with oxygen or without oxygen, and at what rate, and also the max flow that they would like to determine. And then we also spoke to the technologists to understand their process of determining when to ask a question to the fellow or to the provider, and also what the current O2 protocols they follow is, and if there's any challenges that they come across, specifically in regard to the studies that for O2 titration specifically. Initially, I think in the start of our quality improvement projects, we were focusing on adults and pediatrics, but after talking to the technologist and the providers, it seemed like the pediatric studies were a little bit had more ambiguity to them because there was no standardized protocol. And so we gathered information from our pediatric sleep medicine colleagues or attendings as well to understand how they best determine O2 protocols for pediatric patients. And this is kind of what we got overall feedback from the technology standpoint. There was uncertainty in the specifics of starting oxygen, as Yama kind of mentioned, the route, the rate, and whether it's for temporary or for home use, also the max flow rate. And they were also mentioned that there was no standardized protocol in place for O2 titrations for pediatric patients specifically. And then from our sleep medicine team in pediatrics, they confirmed there's no official guidelines on O2 titration studies, but the goal was to keep O2 levels above 90%, and in neonates classified as 0 to 12 months have different O2 requirements than those above 12 months. So that was also playing a role in the ambiguity of the studies. And now kind of talking about data collection from.
So, with what Omar said, to continue on, like how we initially got the data and then eventually stratified it to pick the pediatric studies. We went through a 2-month time frame from August 1st to October 1st. We got the reference numbers for the patients and further stratified them, pediatrics from adults. And then from that data, we further had a breakdown with how many of these pediatric studies had an oxygen titration study, how many of them resulted in patients needing a O2 retitration study due to lack of clear instructions about oxygen titration, and how many of these studies had the oxygen titration study done in accordance with instructions by the physician. That's kind of a nuance because sometimes they did reach out to us for that multiple times, and we have to reach out to the provider to actually place it in. So from that, sorry, I went off again. We identified a problem in which was 47% of the pediatric oxygen titration studies in a 60-day period lacked detailed instructions, which could adversely affect the cost and quality of care. Specifically, the instructions lacked indications to increase oxygen flow rate, the incremental flow rate for the titration for the supplemental oxygen setting. So like 0.5 or 0.25 is a good example. And then like what would be the max? Because this whole which we'll get into more detail in a bit. So this is since it's part of the Gamble walk, we have to always go back now to the root cause analysis. And like this picture shows, the one with the kid, we always keep we found the problem and we have to say, why is it happening? And then from that, say, why is that happening? And then keep doing that over and over and over again. So what we came up with, was so a problem was the order didn't actually have required instructions. And then so we went back to why is that? Ordering providers may have not known the required instructions. So why did that happen? The order did not actually have the prompts or anywhere to actually put in the information other than like a comment section, let's say. And that leads up to what we think may have been like a root cause of a problem. Now to move on to what we did to try to change and help implement the next steps. Coral will continue on.
Yes, so the next step is the countermeasure development. So through this whole process, with everyone's involvement, multiple different providers, multidisciplinary, and then we kind of got back together and discussed what all we gathered, every provider's different experiences, and also our own experiences while we're on call. And then we sifted through the problems, and then we developed the goals that really stood out from everyone's feedback and input. And the three main ones that Isaac and everyone has mentioned are the indications for increasing the oxygen flow, as well as the initiation of it with the certain incremental up titrations of it, as well as the maximum flow rate, especially for pediatric patients, as well as depending on their age. So once we identified these three main problems and then hopefully goals that we can help resolve, we also reflected back on the current pediatric oxygen titration order, and that's the current order code that's currently present as well. And then we reviewed those, the current template, and identify that, yes, these goals and problems, we could definitely implement that into a new order set that will definitely and hopefully help address the issues that everyone has been experiencing. We also looked at how to implement this change. We looked into like, hey, should we get a new order or should we keep the old order and update it? So reflecting on that, we looked at both the positives and the negatives of both, and then we felt that keeping the consistent code would be the utmost of benefit. That way, there's a consistency of accessing the order. Because a lot of times we bookmark it, we star it, and everyone's used to this specific code. And that way, there's a consistency of accessing this particular order in order for future data collections as well. So with this development, and going through the implementation of this new order, there were lots of drafting, and then many people were involved in drafting this order. We looked into and talked again, we revisited a lot of providers, and which include lab directors, our sleep technologists, lab supervisors, other specialties. We actually reached back out. We're also working with MyChart and HITS team members too to get their input, as well as not only focusing on sleep medicine providers, but also feedback on general primary care providers too and other specialists too. In addition to that, besides the clinical aspect, we also did another literature search too. We did talk with our pediatric sleep faculty as well, obtain literature search from throughout the years to see if there's any guidelines in a way that could help us develop this order drafting. And then we have worked with our HITS team and MyChart team to hopefully get an order that is easy to use, convenient, efficient, and addresses the issue accordingly. So the next step is this aspect. This is a screenshot of the current revised order that we're going to talk about further.
So I hope you guys can see my cursor here. So this is the revised order. After talking to many of our pediatric attendings, we were told that age plays a big role with how we start oxygen. And so we did put a little prompt here in the corner so that an ordering provider, in case if they're not of pediatric background, we're aware that if a patient is less than 6 months, we recommend that the max flow rate for that patient be 1.5 liters per minute. If they're greater than 6 months to 3 years, it's 2. And then if they're greater than 3 years, it would be 3 liters. So this is just more so kind of a reminder. Of course, the attending or the provider that is ordering can always specify in a comment section down here if they'd rather do a different type of max flow rate. But the important changes that we made included a reason for the exam. Oftentimes we use oxygen for various reasons, whether it's pulmonary hypertension, if we're treating obstructive sleep apnea, or if there is hypoxemia, as well as central events, or there's also a other. This was not part of the original order, and so we added this so that reading providers can understand why that oxygen is used. The other part that we implemented was if the patient uses supplemental oxygen and sleep, and whether to start that with the study or without. Many of us know that if we start supplemental oxygen and if we're looking for OSA, that can often mask the OSA. And therefore we often do studies without the oxygen started. And therefore this question is to make sure that we are fulfilling the wish of the ordering provider, whether they want that oxygen on or not. The next is the flow rate. So this is the rate at which we increase and do the titration. So for example, this is a starting flow rate. So if we're doing no oxygen, are we starting with 0.25 or 0.5? This is the flow rate and how we're going to titrate it. So do the techs increase the oxygen by 0.25, by 0.5, or other? And that's why this was not in the original order as well. And so we have added this. And then the other part is increasing the oxygen flow rate and what is the criteria for it. So once again, if a provider is doing the oxygen titration to treat OSA, is it to make sure that the apnea-hypopnea index, if it's greater than 5, is that when they want the text to increase, or if they're doing it for centrals? Or is it more for hypoxemia and they have a set oxygen desaturation of maybe 92 or 90%, and if the oxygen is lower than that increment for a set period of time, is that when they want to be started? So more possibly of a hypoxemia, or if it's a obstructive or central apnea. And so this is what this allows the ordering provider to kind of put in the criteria. So these are the changes that we have made. The current order just had whether the patient was on oxygen and whether this was a titration or not. So these are the changes that we have made. And so in order to kind of implement these, once this order set goes live, we do have to reach out to all these ordering providers, let them know that there is a revised order that they should be using for pediatric O2 titration. And so we had the idea of possibly letting and also letting our supervisors or techs know as well. So we would be emailing the techs managers. We would also try and see if we can notify pediatric pulmonologists and neurologists. We often see that they are ordering providers as well. We notice that in the biweekly sleep updates, oftentimes we have a little section at the bottom that kind of talks about some epic tips. And so we were wondering about possibly even adding our countermeasure to that email, as well as creating a tip sheet that can be posted, whether it's on SharePoint, whether we have a little bit of a presentation after grand rounds, and also including it in the MyCare tips as well. And so after we do our countermeasure, after the order goes live, we want to allow providers to use this new revised data or this new revised order from February to March. And after that, we would want to go back and do data collection again and to see if there is a decrease in the number of orders that were lacking the appropriate titration instructions. And we are hoping that it is less than 47. Our goal is that it would be 20%.
You weren't gonna look for numbers of calls to fellows on call about oxygen titration? Secondary outcome.
That secondary, yes.
And then, sorry, and then the chart that's right next to it, we looked into that to give us insight on how many times this order has been being used, at least for the past year or so, as well as the different types of providers that have been ordering it. So that way we have the grounds of kind of moving forward, what to expect, other barriers that we may encounter in the future. So based on this, it shows that majority of this specific order, a pediatric O2 titration study order, is mainly specialty based, especially sleep providers, 89%. There were very few non-sleep providers, only 11% that ordered that. And then when we looked into the non-sleep providers versus sleep providers, that included not just only sleep, but also like neurology sleep, palm sleep. So it's a mixture of those. But it also gave us good insight on once we get the data back with the new updated order and then see how this new implementation is being utilized in the system, we can then go back and see how this order is going smoothly, because some of the buttons, they are the red flagged, and then some of the areas also have the comments, and that's why we added that. So that way we can also assess if there's any issues with the order set in association with the specific types of providers that have been ordering it.
Oh, so sustaining progress. So after all this hard work, we want to make sure that, this is something that can continue to not only help, the patients that we see, but also ordering providers, fellows, technicians, everyone involved, right? So the way we want to sustain progress, kind of what Nisha had already mentioned, was, updating clinicians, technicians, and the providers about the new revised order set via emails, monthly emails, and also maybe speaking up their didactics, for example, would also be helpful. Maintaining a tip sheet that can be placed in the fellows room, pediatric sleep clinic, as well as sleep lab, so that anyone who wants to refer to it can refer to it. And then checking with clinicians and technicians over the next few months to gain their feedback on the pros and cons of the new revised protocol. And then we want to really standardize the process by promoting clinicians to use the order prompts. That way, with a standardized process, there's less ambiguity going forward. And yeah, and then lastly, I know a lot of people worked on this, so Bruce.
Yeah, we just like to thank everybody on this list and others. Our PD, Dr. Shalgakar, she put a lot of effort in, kind of guiding us through the whole process and teaching us a lot of things on the way. And those morning conference, the time we spent during morning conference was quite helpful. And we did enjoy working with her under her guidance, and Dr. Lisa Matlin, as well as Dr. Fozia Hassan and Dr. Timothy Hoban and Dr. Vera Vigram. The pediatric team was quite helpful and useful because this is obviously dealing with children. So their kind of feedback was essential to how we designed the whole order set. So thank you all for helping us there. And then our technologists, sleep lab providers, and other specialty providers. Your input was also very valuable because this, I think, as a reflection, this is going to make the fellows' lives easier and hopefully the technologists' lives easier as well. Kind of having something that's more standardized at our institution is going to be very helpful in terms of getting these, maybe doing these studies without any hiccups and obstacles throughout the night. So hopefully things get easier with this new order set. Oh yeah, and so this was when we were asking different providers for their input. I was in charge of talking to ENT and seeing how they actually order these studies. The specific provider was not available that week, but they did mention I could scrub into the OR to speak to him. So I did take the initiative and I scrubbed in. And I sent this picture to the fellows in the group chat, and they thought it was really funny. And we included it in the at the end of the presentation.
Strong work. I love that.
Any questions?
Yeah. Great job. There's a question from Dr. Turbing. Go ahead, Ron.
Hi, great presentation, and yeah, and both the didactic background and then on what you did. What percent of the titrations that we do end up being unanticipated? Like, they didn't know they were going to need it, but they end up, or any, or and if so, then how is that is that impacted at all by these new protocol?
So a lot of us did the data collection, and a lot of times there was a couple that were basically exactly what you said, unanticipated oxygen titrations. And that's a lot of the times that we get the calls.
Overnight at least.
Yeah, overnight.
Yeah, overnight. So that then comes to us, and then in a way then we have to make that decision. But I think even going through this QI project, I'm a lot more aware of how to answer that question in itself. Looking at the age, looking at what are some of the recommendations that the pediatric providers do use. So it does help us in that. We didn't specifically look into that on how many or what was the percentage of the ones that were turned into titrations.
Yeah, if I could add on to that too, I think as part of the scoping process, that's when they decided to narrow the scope and focus on the ones that were ordered as O2 titration studies, because it was a little bit more heterogeneous if you include baseline studies, split night studies, things like that. So then the scope was narrowed to dedicated O2 titration.
They're interesting questions, and also, the purpose for an O2 titration isn't always the same. Like sometimes it'll be because of persistent hypoxemia, but so for those of you who might have encountered it, we're doing the DOSA study, which is the OSA and Down syndrome children as a research study. And for that one, there's like, I don't know, 7, 8 sites. Fazia works on it too. And for our site, and we have to have the same procedures across sites. So we actually have a O2 titration protocol that tells you you're going to spend like a half hour on this setting and then go to the next setting and a half hour on that setting. And, you go up and then you go down and then you cycle up again and go down. And then the study is reviewed centrally so that it can be the same approach. And then we're told which one worked best, but can't possibly take into account, all the different sleep stages they saw in what positions. And in developing the protocol, we raised the point, maybe we should just have it done by, with some clinical judgment of the fellows, but they didn't want to do that because it was too non-standardized. I don't know if Fazio want to say anything about it, but in this case, it was to treat these children with OSA who had failed tonsillectomy and refused or failed CPAP. So it's a little different than what you were thinking about, I think.
I think it brings a good point, Ron, in the sense like, what are we treating? What are we using oxygen for treating, right? Is it hypoxemia or is it OSA? And then I think oxygen is one of the things that is most non-standardized in what we use, right? So it's like, if you get REM supine, do you not get REM supine? Are they sleeping supine at home? Are they not? And it's so many variables that it's so difficult to standardize. And I think those of us who do this long enough it's so tricky. And if you leave it to any one of us, it's like, how many variables do you really look for in that one night of sleep? It's overwhelming for
Maybe
all of us.
AI is going to solve this at some point.
I know. It would be really great. Like you ask the patients when they come in, like, do you sleep supine, non-supine, and you get an automated protocol that just gets printed out. Like that would be very cool. But I think in the limitations that we have right now, it's still, I think among all our societies as well, the ATS, the ASM, there is no standardization of use of oxygen, right? Like we don't even have a standardization of what is hypoxemia during a sleep study. We can't even say if it's continuous or cumulative minutes. So that's how far out we are. Like that's how muddled we are. And really for OSA, if you go to different literature, it doesn't even say how well we should. Some of it is don't use oxygen. Some of it is how do you use oxygen. So it's like very varying. And I think with Ron and I, what we've seen is we use oxygen. It's somewhat optimal, but somewhat at times suboptimal. And then what does it do to your CO2? So, and then which position do you also use it at? Like if you use it supine, and then the child is not sleeping supine, then what do you do with these results? So,
not to mention the in DOSA, I think that they take in before we're told about the titration and what the maximum oxygen rate recommended is. I think it's these factors you have here, but I think they also look at the baseline study and see, for example, how much the hypoventilation is. I think that's might be the main thing, but do you know otherwise, Fazia? Besides the weight or besides the age of the child?
I think it's the age of the child, and I don't know if they took weight. The current, like they have that table. I'm trying to go back and remember. I'm having a very senior moment. I thought it took the weight also into consideration for it. But I can check. But it definitely took the age into it for the flow. I think there was a weight consideration into it as well. When Scott had sent that over.
Well, does this order form have a space to put in added details?
So that's what we were all discussing. It's not the it's not the last. I think I just reviewed it this morning.
Yeah, it does have order entry boxes. I'll let the fellows can speak to that. or comment entry boxes.
Yeah, so all of these, if we want to do something different other than what's recommended, it's here, and I believe they're even at the bottom, which I think it got cut off here. There is a comment section as well, so if there's something different than anything that's up there, you can also comment about it.
And then for Ron's thing, it has, besides the preferred site, there was going to be other site, like I know we're doing oxygen at the off-site as well.
Well, looks like excellent work to me. It's 2 steps forward, yeah. That's what we need. So, very thoughtful.
Yeah, I'll add too that the fellows also noticed, in addition to the other things that were mentioned, just that there are patients, we didn't quantify it, but patients for whom they have to come back for additional studies because the instructions weren't clear on the front end. So, I mean, they even brought that patient-centered lens to this question too, of how to avoid repeat studies, or, you know, how to effectively utilize the very intense resource of the sleep lab to make sure that the right study's done when a patient comes in. I don't see any other hands up.
I'll just mention this is an important work in part also because of what happened a year or 2 ago at Boston Children's, where a patient actually passed away in the sleep lab, and it was because of oxygen issues. So there were some meetings that we had about how to proactively try to reduce chances that would ever happen here. This was a 6-month-old, I think. There's been some written on it already. All across the country, people I think are trying not to have something like that repeat. So yeah, the oxygen in some cases is life or death. So
Well, kudos to the team. You all did a fantastic job on the project and on this presentation. So
Thank you.
great work.
Thank you.
There are some kudos in the chat too, if you all are seeing all the comments coming.
Thank you guys.
Thank you. Thank you.
You guys.
Thanks.